And now we're on to chest seals.
Yeah, so when we're talking penetrating trauma at this scope of practice, it gets pretty simple. There's a couple great rules of thumb that you can follow, and one is if you have any break in the skin between the neck and the navel, put a chest seal on it. And the big question is always vented or unvented. The recommendation now is vented, and the reason why is because air can escape. If air is able to escape, the vented chest seal will let it escape without letting any air back in, and then reducing that basically the dead space in the pleural space, help the lungs function a little bit better. So when the patient inhales, it presses air out, the lungs inflate a little bit more, and the air that's filling that space will go out and hopefully not return through the vented chest seal.
So if you're worried, so if you've got a wound here, you said that there's any break in the skin from neck to navel, why would the abdomen be risky for us? Why would we want to put a chest seal?
Yeah, so when we inhale really, really deep, the other lobes of the lungs can reach really far down, right? And so penetrating trauma doesn't always move straight, and we also may not be able to see the entry and exit. So so you just plan to treat the systems above and below. And so just anywhere between here and here, we're going to throw on a chest seal. Gotcha. And the big question is always vented or non-vented. If it's moving air, vented. The standard is vented, but if it's moving air, especially vented. If it's not moving a lot of air, and I'm limited on resources, I may wait and monitor it a little bit, or I may put a non-vented chest seal. So let's take a look at the vented chest seals. What we're talking about here is the Halo. It's kind of the one that we're using. It's a great chest seal, been around forever. This particular way, it's packaged with a vent and a non-vent version inside. And taking a look at it, when you open the package, you have it's very clearly marked vent and non-vent. Even so, at night or it's dark or whatever's going on, you may not be able to recognize, but the seals look different. So that's kind of the way most of them have a differentiator between, so it's very clear to tell vented or non-vented. And in the laminar flow chest seals, because there's not a mechanical vent, it may not be completely obvious. Because people see the hole in the middle, but what they don't see is the 4 vents on the corners, right? So that's where the air actually goes out of. So it may not be apparently obvious. So most manufacturers have marked very clearly on their product which is which. So a couple things when we're talking about chest seals. I want the vented one on the one that's moving air, and I want the seal to go on the largest wound. So we talk entry and exit. You're going to have to roll your patient over, assess the back. You may not have an exit, or you may not have a secondary wound. You may not be able to tell the difference between entry and exit. So you just kind of have to do your best and solve the problem. So when we're looking at chest seals, one of the big things across the board on chest seals, they have this hydrogel type material, and it's very, very sticky. And it actually came out of attaching like charges to doors and things like that, attaching other things to things. And then medics said, hey, that works out pretty well. Started cutting the breacher's hydrogel up, using it as chest seals, and then they started making these, and then people started using these for that. So it's been a great evolution of that equipment, but very sticky. So one of the issues that happens, I see this a lot in training, people tear the chest seal off like this, and they're going to go. Well, this particular one, the Halo is nice because it's got a stiff backing, but if it doesn't have a stiff backing, the chest seal can fold over on itself. And this hydrogel is so sticky that once it folds over on itself, it's very hard to undo. You're almost better off throwing it away and just getting another one. So this one does pretty good, but it's hard. And imagine I've got gloves on at the same time and everything else. So I'm going to show you a technique for applying chest seals that it's very similar. It's the way Mom always showed you to put Band-Aids on. It's pretty good. So in this particular model, I'm going to use this wound here on the chest as kind of my guide. So we generally want to have the vent centered over. If there's a single vent in the center, like some, other ones just have vents along the sides. But I want that vent generally roughly over where everything's moving. So what I'll do is I'll place it over the wound and get my setting. If I have a piece of gauze, I can wipe blood away, to make the chest seal stick pretty good. These do really well on hair because the hydrogel's so thick. They do really well on hair. They do pretty good on sweat, blood, things like that. But you should try to make an attempt to wipe it away. But then with the backing on, place the seal over the wound. And then all I'm going to do is I'm going to pick up the edge. I'm going to pick up the edge, peel, keeping my landmark, fold, and then attach to the skin, right? And then lift up and then smooth everything out. So by doing that, I'm doing two things. I'm ensuring that my seal is centered over my wound, and also I'm making sure that I have a nice controlled motion to put that chest seal out. Because, like I said, once it sticks to itself, something else, dirt, I drop it, you're pretty much done. And like I said, the halo is great because it's got this nice stiff backing and it peels off pretty much flat, but not every chest seal is that way. And they can be a little bit expensive, so you don't want a whole lot of waste here. The other thing you can do is if you have multiple shots, you might be able to cut your chest seal up and cover different things. Chest seals are a great, they're a great force multiplier in any IFAC because I can use them to hold tubes in place. I can do so many things with chest seals besides just seal holes in chests. They have a lot of different uses, from securing surgical airway sites, chest tubes, whole bunch of other, just pretty much securing everything. So they're really good for that. And they come off, they peel off fairly easy off of the human skin. They just, when they stick to themselves, they stick to themselves. Mm-hmm. So like I said, vent and non-vent, just same thing. Make sure you check for a wound in the back, put your vented chest seal where the air is moving, and then position your patient generally in their position of comfort, but a couple things to consider when you're positioning your patient. So with your vented chest seal, it'll vent both air and blood. So just keep in mind what's causing your problem, because you'll have air. If you have air, you'll most likely have blood. And you just have to make sure that your patient's positioned appropriately to vent what you need to vent and keep them comfortable. We know that no matter what, blood is going to go down because of gravity, and air is going to go up because that's what happens. I can show you that with a water bottle or some other, but blood's going to go down, air is going to go up. So depending on what your injury is and where your injury is, that's going to determine how you position your patient.
Okay. Now, I was taught to apply it when the casualty was on expiration, right?
Yeah,
How important is that?
On exhale is generally the best thing. But now that we have the vent, eventually it's going to vent that air out. So it's a great thing to keep in mind. But once again, as you start stacking that information on, is it more important to just have a chest seal on, right, or is it more important to make sure that they put it in with exhale? So yeah, that is generally the rule of thumb, something I still do. But a lot of people forget that. I see that a lot in training. They just throw that thing on there. It's the nice thing with the vented chest seal. Not as critical with the vented chest seal. So.
Love it.